The first speaker is the esteemed Mitra Nadim, who will talk on to dialyze or not. This is the question.
Do I just go? Okay. So I'm going to start, good afternoon, and I'm going to talk about dialysis or not. I'm going to start off with a typical case that I see a lot in my hospital on the liver patients. A 65-year-old, known history of alcoholic cirrhosis, presented to the hospital with abdominal pain, decreased urine output. He had quit drinking 6 years ago, but 2 years ago, after his wife passed away, he restarted drinking. On presentation, his blood pressure was low, heart rate was 102, temp of 38. He was on oxygen with a low oxygen saturation. He was lethargic but arousable, distended abdomen, swelling in the extremities, and he had a white count. INR was elevated, BUN and creatinine were elevated. His workup revealed SBP, and he was started on antibiotics. 24 hours later, he became more somnolent, hypotensive, hypoxic, and acidotic. So the question is, what is the fact? The fact is, if this patient doesn't receive any organ support, he's going to die. Now the question is renal replacement therapy appropriate? And the things we consider when we think about it, and this can be generalized to all patients in the ICU, is what is the chance of short-term survival from the ICU? Are they going to make it out of the ICU? What's the duration of therapy that you can estimate that will be required for this patient? What is the long-term outlook, the hospital mortality? And a lot of times, patients may be able to leave the hospital, but they're not going to be able to tolerate dialysis. What is the cost of all of this, should we be asking ourselves? And in the case of a transplant, whether it's a liver, waiting for a liver transplant or heart failure, does his transplant candidacy impact your decision? And then you have to take a pause and say, would your decision, if you decided you won't offer dialysis, would it change if this patient now was 30 years old? What if he had 2 young kids? We frequently on selection committee, everyone says, oh, the patient has kids and we should probably offer something. What if it wasn't alcoholic liver disease and it was something like hepatitis B? Well, now NASH is a different name, but what if they didn't know they had alcoholic cirrhosis? What was the reason? Is the reasoning different for you? When was his last drink? And again, do these things impact your decision on whether or not you would offer dialysis? And this is a typical scenario we see in high MELD regions. These patients are on antibiotics, pressors, TPN, and all the stuff that Ravi just discussed on the green ICU. This really has a green sheet and a green dialysis machine. But the question is whether or not you should offer dialysis, and and if you do offer it, when should you withdraw? And this is something we constantly are battling with in the ICU in critically ill patients. And again, it's, we are stuck in if you offer it or if you don't offer it, and it's because we don't have right answers on the prognostic implications of our decision. So if you don't offer it, are you denying a life-saving treatment to a patient who potentially can be saved? But if you're initiating it, is this going to be indefinite suffering for this patient who has no destination? And it comes down to, again, what the reason we struggle is, can we predict futility? Because that really makes the decision of what we offer to patients. And the answer is really not as simple as we think. This is, again, from Hippocrates, that how do you define, medical futility was defined, refuse to treat those who are overmastered by their disease, realizing that in such cases, medicine is powerless. So what are the problems we encounter when we're considering withholding or withdrawing dialysis based on futility? Well, first of all, what is the definition? There's so much controversy of how do you define futile treatment? Or again, nowadays we don't want to use, people don't like using the word futile and more non-beneficial. Then there's this balance between the physician's authority of knowing what is right or wrong, supposedly, versus the patient's right. And the patient's right, and sometimes they don't go, they're not on the same kind of wavelength, and the patient's right, does that take precedence over the physician's authority? And I think the reason that we struggle so much is there's not much data that we can confidently tell patient or identify those who will or will not benefit from certain treatment, especially renal replacement therapy. And there are patients I've had experience where I really thought that there was no way they could make it. They were on 3 pressors, but they got the right antibiotic, and all of a sudden they're off pressors and out of the ICU and hospital. So again, the data that exists for mortality rates that are approaching 100%, and those are the patients that we can say, okay, definitely we're not going to offer anything. There's not enough data out there. And then there's this, you see all these news that come out, and I hear this frequently from families, that all of a sudden, well, my loved one we've read that someone woke up after 20 years, so you're telling me you're not going to offer dialysis because you're going to, this can happen, this miracle can happen to our families. And again, it's a big thing in the US where you have lawyers sitting behind every hospital door. So what makes dialysis different from other life-sustaining modalities? Well, the first thing is the interval between the clinical indication, the need for it, and the need to act are different. So if someone becomes suddenly hypoxic, short of breath, or has cardiac failure, within seconds you have to act on that patient. AKI may take hours to weeks, you have more time to decide, and it's not isolated, and it includes other aggressive treatments of the patient. And then the other one is the indication and optimal timing. We have, there's, let's just say ACLS protocols, what to do for resuscitation of patient. But for renal replacement therapy, again, there's those who wait until the patient is comatose and unresponsive versus you starting early. So this not knowing when to do this makes it different from other life-sustaining modalities. So then comes this time-limited trial. And what is this time-limited trial? It's a middle ground. It's between indefinite life support and comfort focus. So basically you're in purgatory, trying to figure out which way to go. It offers patients this chance of possibly survival, and it justifies all the other treatments that we're doing, and compared to the risk of this negative dying experience. The definition by the American Thoracic Society that just came out a year ago, it's a collaborative plan among physicians and a patient or their surrogate to use life-sustaining therapy for a defined duration, after which the patient's response to therapy informs a decision to continue care focused on recovery, transition to care focused exclusively on comfort, or extends the trial's duration. Very vague, but this is the definition. And the interesting thing is, which I learned, that the Renal Physicians Association, the ASN, in 2000, so that's about 25 years ago, came up with a definition: consider time-limited trial for renal replacement therapy for patients who have an uncertain prognosis or for whom a consensus cannot be reached about providing dialysis. So what is time limited of renal replacement therapy? The first one, really, I think it helps resolve conflicts with physicians, is a bigger problem than the physicians and the families. But this helps if you come up with a time, a limit of time that you're going to offer something. But it also depends on the cause of AKI, what the prognosis of the patient is. It should be flexible. And again, as I was preparing for this talk, I was reflecting on what I do in the ICU, and I realized the way I've been offering time-limited trials is completely wrong, because I would set a time, and then I wouldn't change it as the patient. If the patient even got slightly improvement to the family, that's improvement. But I would say, well, nope, I gave you 48 hours, you're not off dialysis, you're not off this, you're not awake. So again, we should be, as physicians, flexible. We should be arranging for reassessment, again, when you start. Usually it's CRT, hemodialysis is less likely, but usually these are critically ill patients. We should be planning, constantly reassessing, and if the goals change, that we should be flexible with changing this instead of being very rigid at a time that we select. And then decide, again, you renegotiate with the family. And clear communication of prognosis. And again, I think we fail as physicians to really tell the truth to families, to really tell them what is, we kind of go beat around the bush trying to tell them instead of saying, this is what your loved one is going to look like. And barriers to time-limited trial, really the lack of consensus between treatment teams, between the ICU team, nephrology team. Again, with the liver, we have issues with their hepatologist. Heart failure, we have problems there. A lot of times our fellows complain because the ICU team goes in telling the family, well, your kidney's not working, we're calling nephrology to dialyze the patient, and we go there, we're like, I don't want to offer anything, but you're stuck because the family has already been told, and they hope that this is going to, save them. Changing teams, often we have families now that know exactly when the teams are changing, so when I write, I'm not going to offer, and then the next week someone else comes and they get reconsulted and they start offering, dialysis. Lack of communication, again, between the families. We don't know prognosis. There's discomfort with using a surrogate if the patient's not awake. And really this feeling of families always saying that we want everything done. And sometimes we have to stop and ask the family, what do you mean by everything? Because it's a very vague word. What do you expect your loved one when they leave here to be able to do? What was their goal of a life leaving the ICU? And so how well are these time-limited trials? This is 2 universities in the US. They gave them 3 vignettes on mechanical ventilation, CRT, and nasal cannula. 35% of the intensivists had not even heard of time-limited trial. And if you look here, I just picked the one for endpoint. What endpoint? And again, I reflected back on myself. I don't even offer an endpoint to the families, but what endpoint? So I say, okay, in 48 hours, what am I looking for? The potassium is going to be better, acidosis is going to be better. And you can see for CRT, there was no agreement with the clinical endpoint for CRT as when you offer time limited. And the barriers to time limited was consultants disagreed with the ICU team, and that gives mixed messages to the family. So that is a big, big issue. At least with mechanical ventilation, the decreasing FiO2 was considered as an endpoint. But again, for CRT wasn't. So does it improve outcome? It's actually 3 hospitals in the county system of, I just found out, in Los Angeles, one of them being where I work, which they looked at, what they did was they started training physicians. It was a 4 to 6 week course, and this training included focused groups of physicians to identify barriers to time limited, didactic teaching, and family meetings. And what they looked at then is ICU mortality before and after did not change, but the length of stay in the ICU dropped from 10 days to 7 days, and this is significant when you think of cost. The hospital length of stay decreased. Mechanical ventilation went from 90% to 75%. And even though renal replacement therapy was not statistically different, you can say it dropped from 20 days to 9 days. This is a huge cost saving, again, with no difference in outcome. And I'm going to say a few words about surgical, because one of the problems in our hospital, it's 90% surgical patients. And this is a very nice quote. When the patient of an internist dies, his colleagues ask, what happened? When the patient of surgeon dies, his colleague asks, what did you do? In the US, there's metrics, and the surgeons are held accountable for every mortality less than 30 days. So a lot of times they don't want palliative care involved. They don't want, they want everything offered until they reach the 31st day. And this is a survey of 2,100 surgeons, 56% response rate. And you can see the percentage of surgeons who would withdraw it depended whether, if it was a surgical error, they were less likely to offer, withdrawal of life. If it was an elective surgery, again, less likely. If it was a surgical error and elective, it was the least amount. And the surgeons who didn't withdraw life support reported, they were more optimistic about the prognosis. But really, it had to do a lot with this 30-day that they're held accountable. So going back to the patient that I presented, high MELD does not mean futility. It's a predictor of pre-transplant, not post-transplant mortality. This is data that we collected from UNOS. You can see on the left, their wait list is high wait list depending on MELD, but if they get to transplant, which is on the right, their outcome is very good. And there's predictors in liver patients. If they come in with one organ failure on the left, you can see if by 1 week they reach 3 organ failure, their mortality is 90%, versus if they come in with 3 organ failure, but by the 5th day they have no organ failure, they actually have good outcomes. And so this is from the from our ADKey ICA consensus that patients listed or undergoing evaluation for liver transplantation, initiation of renal replacement should be viewed as a condition optimization bridge to liver transplantation. If they are not a transplant candidate, recommend discussing with the patient and caregivers, again, because their mortality is quite high. Just going to end with one more slide. What about palliative care? There's 2 models. You can either start palliative care after the patient has failed a specific therapy. Usually that's done for younger patients, but again, for patients with liver disease or heart failure, I think the comprehensive where you start palliative, and unfortunately we don't do that, and then so that throughout the course of the patient's hospitalization, they can be there. So going back to my title, dialysis or not, really the decision is it has to be an approach, a multidisciplinary approach between the intensivist, primary team, nephrologist, and the patients. Thank you.